Good afternoon, everyone. Welcome back to yet another series of Learning with Masters from Sankara Academy of Vision. Today we have a discussion on management of astigmatism with contact lenses. Our faculty from Bangalore, Ms. Ashwini, is going to be talking about it, and Ashwini is a bachelor from Sankara College of Optometry and master's from Manipal University. She has an interest in contact lenses and practices and teaches contact lenses. Over to you, Ashwini.
Thank you, sir. Good afternoon, everyone. Today we'll be having a discussion about the management of astigmatism with the contact lens. Before seeing what is the management options available for the astigmatism with the contact lens, I would like to have a small discussion about the basics of astigmatism. Rays of light rays are coming from the infinity. It doesn't focus on the retina. There will be there is no point image formation, and the horizontal meridian rays will focus at one point and the vertical meridian rays will focus at the other point, because of which the patient may feel the blurriness of the vision in this condition. Again, based on the etiological classification, see complete total eye astigmatism. Again, based on the refractive status, again there are 5 types of the astigmatism. The first one is the simple myopic astigmatism. This is due to the, in this condition, the one particular meridian ray will focus on the retina and the other meridian rays will focus in front of the retina. This is called as a simple myopic astigmatism. In a simple hyperopic astigmatism, one meridian rays will focus on the retina and the other meridian rays will focus behind the retina. Then comes the compound myopic astigmatism, where both the rays will focus in front of the retina, but there will be 2 different focal points. Again, there is a fourth one, that is a compound hyperopic astigmatism, where both the rays will focus behind the retina, but it will be in the 2 different focal points. The last one, the mixed astigmatism, in which one particular meridian rays will focus in front of the retina and the other meridian rays will focus behind the retina. And here you can see a picture where in the first condition, in the left hand side picture, you can see in the first picture the person doesn't have any kind of refractive. It's an emmetropic condition. In this condition, the person or the patient will perceive the clear image in all the meridian. That complete image will be clear. But whereas in a spherical refractive error, when a person is having spherical amount of refractive error, in all the image will be blurred, that all the 360 degrees. But whereas in the astigmatism, again there are two types are there. That is a regular astigmatism and the irregular astigmatism. Again, in a regular astigmatism, there are 3 types. In the width angle astigmatism, where the principal meridian rays are 90 degrees apart from each other, in this vertical meridian will be more steeper comparatively to the horizontal meridian. So because of which in this condition, patient will perceive the one meridian image more clear than the comparatively to the other meridian. In the against thermal astigmatism, similar like a with thermal astigmatism, in this principal meridians will be 90 degrees apart from each other, but whereas in the horizontal meridian will be more steeper comparatively to the vertical. Again, in one particular meridian, the person will perceive the image more blur comparatively to the other. In oblique astigmatism, the principal meridians will be 90 degrees apart from each other, but the axis will be, the astigmatism will be present somewhere between the 30 to 60 or between the 120 to 150. Again, there is an irregular astigmatism, one more type, in which there will be a principal meridians will not be 90 degrees apart from each other, and the difference between 2 principal meridians will be less than 90. And again, there are 3 types based on the magnitude of the astigmatism. There are 3 types that it is classified as follows. Like mild astigmatism, when the astigmatic dioptric power is less than 1 diopter, it's considered as a mild astigmatism. If a dioptric astigmatism power is 1 diopter to 3 diopter, it's considered as a moderate. If the astigmatism power is more than 3 diopter, then it is considered as a severe astigmatism. And before going how we can evaluate or how can we manage the astigmatism condition, for that we should learn or we should know about why should we know about the astigmatism. There are so many evidences and the studies done in which they have compared the three type of refractive error, and they have seen which is the most commonly seen among the population. There is a study done by Ms. Srini H. et al. In 2018, which is a systematic review and the meta-analysis paper. In that, they have observed in the children population, they have compared all the three: myopia, hypermetropia, and the astigmatism. In which, after the result was shown that the astigmatism was most commonly seen in the children, that is around 15%. Again, when they also look for observe for the in adults population, they got to observe that comparatively to myopia and hypermetropia, astigmatism was seen around 40 to 41%, whereas myopia was around 25% and the hypermetrop was around 12 to 13%. This study was done worldwide population. But whereas again in India also there was a study done by Ms. Sheila Devi et al. In 2018. Again is a systematic review and the meta-analysis, in which again they have compared the astigmatism, myopia, and the hypermetropic refractive error. Again in the Indian population, when they observed that the astigmatism was most commonly seen comparatively to myopia and the hypermetrop. Astigmatism was around 5.3%, myopia was around 5.2%, and the hypermetrop was around 2 to 3%. So based on these evidences, based on these studies, we can tell that among the common population, the astigmatism was most commonly seen refractive error comparatively to other refractive errors. So it's very important. We may see in our day-to-day clinical practice, we may end up seeing the more astigmatism patient. That's why it's very important to learn about the astigmatism and also how to evaluate and manage the astigmatism. Then comes to how can we identify the astigmatism. There are various methods are available. Like a basic one, we can like always the visual acuity gives the gross value of the amount of astigmatism may present. Again, the decrease in the visual acuity depends on the severity of the astigmatism. Then comes the retinoscope. When we perform the objective retinoscopy, again when we perform the objective retinoscopy, we get to see the cylindrical cover. That is, the horizontal and the vertical meridian may have a different refractive error. This one, the objective values we can confirm with the subjective acceptance by doing we can use the Jackson cross cylinder, in which we can confirm the cylindrical axis also and the cylindrical cover also. And other than that, there are other two more methods are there. That is the astigmatic one, in which we can confirm the cylindrical axis. Also, with the help of the stenopic slit, we can confirm the cylindrical axis. And other than this, also there are imaging techniques available. Here you can see a picture of the op scan, in which we can identify the anterior corneal topographic value we can get. But again, there is a updated versions are there. In that, I have taken the pentacam picture here. You can see with the help of the pentacam, it is also one type of the imaging technique. In this, we get to see the anterior and posterior corneal curvature, and also we can compare the astigmatism power between both the eyes. Also, we get to see the thickness of the cornea, and also we get to see the anterior lens curvature also. So these are the various methods are available to identify the astigmatism in a patients. Once we after identify, it's very important also to know the management options available for the astigmatism. Before going to management option, I would like to say a little bit about the prescription. Whenever we get the power that in a two meridian will have two different power, right? So when we put it in a cross cylinder, we get to see what will be the power of horizontal and the vertical meridian. So this one we can write in a spherocylindrical prescription form, whereas a -3 is a spherical power. The difference between both the meridian will become the cylindrical power, and the axis is at 90 degrees. So this is one of way of writing the prescription. Again, in a prescription, there will be a spherical component, cylindrical component. The important one is the axis component. All the three is together it makes a astigmatism prescription. Again, there are optical corrections available, optical management options are available, and also surgical option. In optical corrections, there is a availability of the giving the correction with the help of the spectacle. In a spectacle, if a person is having a spherocylindrical prescription, we can allow in a spectacle toric lenses. And in case if a person is having only a cylindrical power, where one meridian will be planar and only the one meridian will have the power. In that case, we can prescribe the cylindrical lenses. And the second option is contact lenses. Again, in the contact lenses, we have a soft contact lens option and the GP lenses available. Again, in the surgical options, if you see, there are LASIK surgery, photorefractive keratectomy, radial keratotomy, laser-assisted subepithelial keratomyolysis. These are the various options available in the surgical treatment. So it's very important to correct. What will happen if we don't correct the astigmatism? Astigmatism is one type of the higher order of patients. First of all, the patient will have the severe symptoms like astigmatic symptoms, and they will have a blurriness of vision, and they have to squeeze their eye to see the clear image, and also they will, by the end of the day, they will have the stress and the strain in the eye. And also, if we don't correct it, there is a high chance of the impaired contrast sensitivity may occur, and also it will hamper the night vision of the patient. That is why, based on all these reasons, we could say that the correcting and managing the astigmatism is very important. So moving on to a case, in our clinic, in our contact lens clinic, we got to see that there was a patient. The patient's age was around 30 years old, and this patient was a female, and her occupation was she was a software engineer working in the IT area, and her main complaints was she had a complaint of blurring of vision with the contact lens. That is since 20 to 30 days. And along with the blurring of vision, she also was complaining that she's not at all comfortable with the contact lens. Whenever she wears a contact lens, she's feeling very uneasy or uncomfortable. And also, when we went through a further detail about the history, and also we got to know that she is using the spectacle since 10 to 15 years. And she, in her last 1 month back, she visited a clinic and she got a new prescription of the spectacle, and also she wished to try with the new contact lenses. She wanted to shift from spectacle to contact lens. So with the she purchased a new contact lens with a new prescription, but she was not at all comfortable with the new pair of contact lenses. When we went for a further detailed history, there was no significant history of the systemic illness, medication, and the allergies. So these were the this was about the history. Again, when we went for a further evaluation, in her unaided visual acuity in her right eye, it was 1/60. With the pinhole vision, there was an improvement up to 6x. Same within a left eye also. And her present glass prescription, it was minus 4.5 diopter spherical with minus 0.75 diopter cylinder. Axis was 40 dB, and patient was seeing a 6/6, but she had a blurriness of vision, and she was trying to squeeze her eyes when she was reading the letters in the chart. And the left eye power was minus 4.5 diopter spherical. The cylindrical was minus 1.25 diopter, and the axis was 140. Again, she was able to see 6/6 line, but she was again feeling the blurriness of vision, and she was feeling I have to put a lot of stress, then only I'll be able to see clearly. So this was her old prescription, her glass prescription. Again, when a patient was complaining about the blur, though she is seeing 6/6, we did the objective retinoscopy, in which we got the value of minus 4.5 diopter spherical, minus 1.25 diopter cylinder, but the axis was 10 degree. When there was her glass prescription to our retinoscopy value, there was around 20 to 30 degree axis difference was there. In the left hand, when we did a retinoscopy, again we got to see that it was minus 4.25 diopter spherical with a cylinder of minus 1.5 with the axis of 160. So again, we did the subjective acceptance with the power of minus 4.5 diopter spherical, minus 1 diopter cylinder with the axis of 10 degree. Patient was reading 6/6 clearly, and near vision was also 6. And we are performing the subjective refraction. Also, we performed the diaphragm, and there was a rated towards to green, and also we have performed the JCC to confirm the axis and also the cylindrical power, because there was a difference between the old prescription and the retinoscopy value. And also binocular balancing was performed. Same thing in the left eye was also procedure was followed. When we got to see the axis 160, she was able to read 6/6, and the near vision was also N6. So predilation acceptance of the patient was this much. Then also after this we performed this slit lamp examination in both the eyes, and we got to see all the ocular structure, that is anterior segment structures were within normal limit. And also we have performed the IOP. It was 14 mm Hg in both the eyes. Once it is done, we have dilated the patient's eye. Then after that, we perform the dilated refraction also just to confirm the power. In this, the values were minus 4.25 diopter spherical, minus 1.5 diopter cylinder. Again, axis was then. And in the left eye, it was minus 4.25 diopter spherical, minus 1.75 diopter cylinder. Axis was 160. The acceptance was similar in both the eyes. The axis was also confirmed, and it was same like a pre-dilated acceptance. Then again, after the dilated, we also performed the fundus evaluation, where the health of the fundus was within normal limit, so there were no complication or no pathological conditions were seen. So based on the pre-dilated value and the post-dilated values, we end up with the final prescription. That is, the value of the final prescription is minus 4.25 diopter spherical with a cylinder of minus 1 diopter, axis is 10 degree, and the left eye is minus 4.5 diopter spherical with a 1.5 diopter cylinder. 160 is the patient's final prescription. So now what to do? Whether already patient is telling she is not comfortable with the glasses. When we suggested for the LASIK, she didn't wanted to go try with the LASIK surgery also. She wanted to shift from spectacle to contact lens. So now these many options are available for this prescription. But for this patient and for this prescription, among these many options, which is a good option for her? So we had a little bit confusion on this, what to do. So before going to a further evaluation, I would just like to look at the evidences and the clinical corrections available for the astigmatism. And we all know that whenever it comes to a topic on the refractive error, always in our mind it strikes about giving the spectacle prescription. So we had a confusion whether the spectacle is good option or not in this condition. Spectacle is always a good option for the refractive errors. Why? Because it remains in a fixed position in front of the eye. It doesn't mislocate from the spectacle, or it doesn't rotate in the lens. So patient will have a stable vision. But for the astigmatism patient, is the spectacle is a good option or not? We had a confusion. There is a disadvantage of the spectacle in the astigmatism. There will be a distortion on the visual space, and also there will be a meridional variations in the image. When there will be a different in principal meridians, there will be two refractive errors will be present, because of which there will be a meridional variations will be there, especially when they are seeing it binocularly, and also in case there is a higher magnitude astigmatism present, that is moderate to severe astigmatism present, then the spectacle is not a good option. And also in case if a patient is having the oblique astigmatism, the spectacle is not a good option. So for our condition, in case this current in this patient, if you see a prescription, the magnitude of the astigmatism is lying between somewhere moderate to severe. So for this patient, the spectacle is not a right option. So again, if you see in a contact lens, there are various options available. For the higher order aberrations, contact lens is always better comparatively spectacle. Again, in a contact lens, if you see, there are various options are there, like spherical soft contact lenses and soft toric contact lenses. Again, there are evidences and the studies, especially in a Richdale et al. Study done in 2007, and also there are systematic reviews and meta-analysis evidences are there, which says that when they compare the spherical soft contact lens with the soft toric contact lenses, they were especially in the low magnitude of astigmatism, that is less than 1 diopter cylinder astigmatism. When they compared between the spherical soft contact lenses and the toric lenses, they got to see that there was an improvement of the visual acuity around 3 to 5.5 letters with the soft toric contact lenses. So in a low magnitude, when they compare spherical soft contact lens and the toric lenses, toric lens was a good option. And again, also they compared the magnitude of the astigmatism. When the person had around 1 to 2 diopter cylinder, they compared the spherical soft lenses and the toric lenses. Again, there was an improvement in the visual acuity around 8 to 12 to 13 letters in the acuity, that is with the soft toric lenses. So based on these evidences, we can see that when a person is having a low magnitude and a moderate magnitude astigmatism, always better to go with the soft toric contact lenses comparatively with the spherical soft lenses. So moving on to, there is a important option available, that is RGP contact lenses. RGP contact lens is very suitable when the magnitude astigmatism is more than the 3 diopter astigmatism, and also it is very good option when the person is having the irregular astigmatism. But in case there are also limitations present in the RGP contact lens, when the internal astigmatism is having a large magnitude, and also in RGP, when we fit the RGP contact lens, especially the spherical RGP contact lenses, there will be a high chance of residual astigmatism will remain on the eye. That is one of the main disadvantage of the RGP. That is why we always prefer when RGP when the astigmatism is more than 3 diopter. So based on these evidences, I would like to say that the soft toric contact lens was a better option for our case. And also there are few conditions where we can prescribe soft toric and where we can prescribe the RGP contact lens. First, we'll be seeing about the soft toric contact lenses. We can prescribe the soft toric contact lenses in the condition when the prescription will have the high sphere comparatively to the cylindrical power. So in this case, we can prescribe the soft toric, and also when in a particular astigmatism, when we give the GP contact lenses, gas permeable contact lenses, but still if there is a residual astigmatism is there, that is, we corrected the certain amount of astigmatism with the RGP lenses. After that also there will be a small amount of astigmatism will remain on the eye. That one we consider as a residual astigmatism. In this condition, better to go with the soft toric. Sometimes because of this residual astigmatism, there will be a chance of compromising the vision. In that condition also better to go with the soft toric. And the patient, there will be a few patients who will not be tolerable to GP lenses and they will have more discomfort. In that case also better to go with the soft toric. And better to go with the soft toric when there will be a spherical soft contact lens will not be able to cover the corneal astigmatism. Better we can better go with the soft toric contact lens. So in all these conditions, we can prescribe the soft toric contact lenses. And then when can we prescribe the RGP contact lens? When the anterior eye characteristics are mechanically and the physiologically also healthy, then we can prescribe the RGP contact lenses. And then when the patient is highly motivated to from soft to RGP, then only we can prescribe the RGP contact lenses. And we also we can prescribe the RGP when there is a moderate to high prescription, especially the corneal toricity, it is a more than 2 to 3 diopter, then we can prescribe it. And in case when you are giving in a certain amount of astigmatism, when you are giving the RGP, if the residual astigmatism is coming less than 0.75, we can prescribe the RGP contact lenses. And soft toric is also having a few disadvantages, like we cannot prescribe in case where the cylindrical power is higher than the spherical component, then we cannot prescribe the toric contact lenses. Again, there will be a thickness variation in the contact lens, because of which you can see a mislocation of the contact lens. And also in the oblique astigmatism, RGP is always a better option comparatively to the toric contact lens. It is just because of the contact lens design also. So based on all these things keeping in mind, we decided to do a trial of the contact lens with the soft toric instead of going with the RGP contact lens. Before going to see how did we do the contact lens evaluation, I would like to give a small little bit information about the soft toric contact lens. And as all of you know that soft toric contact lens means that both the principal meridians will have a two different power in both the meridians. And it is very important when we fit the contact lens. We all know that when we fit the contact lens over the cornea, there is a high chance of there is a rotation of the lens because of the characteristics of the lids and also the tear film present over the anterior eye. So it is very important to make sure that the lens is stable, and because of this, patient is getting the stable vision also. So all these factors depends on these 5 components. That is dynamic characteristics of the lens. That is gravity, And the lid pressure also important, especially compared to lower eyelid. Upper eyelid pressure is very important, and the corneal and limbal topography, tear fluid forces, that is tear film, and also the thickness of the contact lenses. So to keeping all these things in mind, we have to give a stable lens, and the patient should get a stable vision with these contact lenses. So to make sure that the soft toric lens is stable on the cornea and over the eye, for that there is something called a stabilization techniques in the soft toric contact lens. These stabilization techniques, in a particular part of the contact lens, the thickness will be more, because of which the lens will be stable on the cornea. There are various methods, techniques are available like prism ballast and double slab of, or else it's also called as a thin zone, and the periballast. And the updated version, that is a new design, that is an accelerated stabilization design. In a prism ballast, the thickness of the contact lens will be more. That is, a prism is induced around 1 to 1.5 prism in the inferior, that is a 6 o'clock position, so that the lens will stay in the the lens will not rotate because the thickness is more here. The lens will be stable on the eye. Again, in the periballast, if you see, the prism is induced in the 6 o'clock position, and the in superiorly there will be a thin part of the contact lens. Inferiorly, there will be a thicker part of the contact lens. But how it is different from the prism ballast is, this is a prism-free optic zone. There will, in an optic zone part of the contact lens, there will be no prism medius. So because of which there will be a stability in the contact lens. And then the double slab, in which there will be the stability is maintained in such a way in vertical meridian. That is, superior part and the inferior part of the contact lens is made very thick compared to the, because of which the lens will be stable. And in the accelerated stabilization design, if we see, it is one of the good and the comfort stabilization technique for a patient, in which you can see there will be a thick zone in the 10 o'clock, 8 o'clock, 4 o'clock, and the 2 o'clock position. In these four meridian, the contact lens will be more thick comparatively to the other. What is the speciality of this stabilization technique is, the contact lens mass is divided, the thickness is divided among the all the surface. So because of which the patient will not feel uncomfortable. The lid interaction with the contact lens, it will be equally for the both upper eyelid and the lower eyelid. And as soon as the patient clicks, within a second or within 60 seconds, the contact lens will be realigning with the original position. But whereas in the other stabilization techniques, the comparatively to the upper eyelid, lower eyelid will have more interaction with the contact lens. Due to increased thickness in the inferior part, patient may feel the discomfort. So this is one of the advantage of the accelerated stabilization design. In this, the orientation marks will be in the vertical meridian, that is in the 12 o'clock and the 6 o'clock. So this was about the stabilization techniques. Again, in the soft toric contact lenses, there is something called reference marking, or also we call it as a scribe marking. What are these scribe markings are? Nothing to do with the optical property of the cornea or the optical property of the contact lens. So nothing to do even with the refractive error. These reference marking or the scribe marks just to help us to know that whether the lens is, there is any rotation present in the lens, or the lens is in a virginal position or not. Because it is very important lens to be in a virginal position, because the soft toric contact lens will have the two different meridian, right? There will be a cylindrical covering one meridian, there is an axis meridian. So it is very important to be in the virginal position. So these scribe marks will vary from the one brand of the contact lens to the other brand. In a few brands, it will be in the only inferior part. In a few brands, it will be in the vertical meridian. In a few brands, it will be in a horizontal meridian also. So how can we assess this scribe marks in the contact lens? When a patient is wearing a contact lens, how can we check whether these scribe marks are in a virginal position or not? We can do with the help of the slit lamp. We can assess with the does with the optical section in which we keep the slit width around 2 to 3 mm and the length will be around 12 to 14 mm. In case first look at whether the scribe marks are in the vertical meridian or it is in the horizontal meridian. In case if it is in the horizontal meridian, then align the slit in the horizontal manner. Then in case if it is in the vertical meridian, align the slit with the along the vertical meridian. So based on this, align the slit width and the slit size also. And when you are aligning, make sure that the illumination technique and the observation system is both the coaxial. For example, here I have taken the vertical, in this vertical scribe marks are present. So I have aligned the slit lamp slit in the vertical manner. In this, what you can do is you can align the slit in such a way it is coming on the pupil center. In case if it is in the vertical meridian scribe marks, you should coincide with the slit what you have aligned in the center. In case if there is a rotation present, what will happen? What you can do is in case if the scribe marks has moved either towards your left or it has moved towards your right, then ask patient to blink. Once you observe, ask patient to blink. Look that whether in case in after immediately blink, after the immediate blink, where is there any relocation of the scribe marks to the center or not. In case if there is an immediate relocation, there is no need to compensate the amount of rotation with the prescription. In case after a blink, it is taking little bit amount of time to relocate to the center, then you can make the changes in the parameter of the trial lines. In case if there is no rotation, when you align with the center, the scribe marks are also at the then there is no need to do a compensation. But there will be also a condition when after a blink, there is little bit after a certain amount of time also, the rotation will not come back to the center, that is to its original position. It will be in a fixed position. In this example, you can see it's supposed to be, this line is supposed to be at the 6 o'clock position, but it is at the 5 o'clock position. So also after seeing the whether it is in the center or not. Once you see if it is not in the center, you have to look that whether it is towards the examiner left hand side or it is towards the examiner right hand side. There is something called last rule and the pass rule. Last rule is when the rotation, the scribe marks has moved towards the examiner left hand side, then the amount of rotation you have to do the addition with the prescription. In case if it has moved towards the patient's, the examiner's right hand side, then you have to subtract the amount of rotation with the original prescription. Or you can follow this rule, or else you can follow the cast rule. That is, if the orientation mark has moved like in a clockwise, then you can do the amount of rotation, you can do the addition with the spectacle prescription. In case if it has moved anti-clockwise, then you have to subtract the amount of orientation with the amount of rotation with the spectacle prescription. Here there is a small example. There was a prescription of -1 diopter spherical with a -1.25 diopter cylinder. Axis was 180. This was the lens fitted in the patient's contact lens. There was a scribe marks was in the scribe marks were in the vertical meridian, like similar like this only. When after the slit lamp evaluation, we got to see that there was a 15 degree of rotation was present, and also it was in the anti-clockwise position. That is, from the 6 o'clock position, it has moved towards somewhere around 5 o'clock to between the 6 o'clock. It was moved from its original position. So it has moved anti-clockwise. So the amount of degree of rotation we have to subtract with the spectacle, the contact lens of the spectacle prescription axis. So the patient's final prescription will be, after the compensation of the rotation, it will be -1 diopter spherical with a -1.25 diopter cylinder. Axis will be 165. So this is about the rotation mark. So we should know in which brand, which type of markings will be present. How can we assess this one? And in case if there is a relocation, what to do? And in case if there is a fixed orientation present, based on the movement, the orientation mark movement towards the clockwise or the anti-clockwise, based on that you have to do a compensation. It was about the short detail about the soft toy. Moving back to the case where we had a final prescription evidences and based on the conditions in the patient's prescription and also patient's priority, we went on choosing the contact lens that is a soft toric contact lens. And when we took a brief history in the contact lens, a patient wanted a contact lens for the vision improvement. Also, she wanted to try new mode of correction from the spectacle to contact lens. And the contact lens practitioner also explained the pros and cons of a contact lens. And the patient profession was a software engineer. She wanted to use contact lens in a daily basis regularly, that especially in her work, in her working hours. And as per the prescription, soft toric was suitable for the patient. Also, patient had a history of using a soft toric. So we went on with the soft toric. And also patient had a history of using the CL from last 1 month. And the patient use was also soft toric. And we preferred monthly disposable. This is the replacement schedule. And the wearing modality was daily wear contact lens. And patient was already using a certain the patient was already using one brand of contact lens, but she didn't wanted to continue with the same brand. She wanted to shift from the brand A to brand B. But also she already had in her mind that which brand she wanted to shift from which. Like a patient was using a brand A contact lenses and she wanted to shift to a brand B contact lenses. And when we compared the properties of the brand A to brand B was also more suitable. So as per the patient's wish and also for her ocular health and the work environment and also her prescription, when we saw brand B was a better, so we went on doing a trial of the contact lens with the brand B only. So we avoided the brand A and we went on with the brand B contact lenses. So before going to trial of the contact lens, her BGC, that is the acceptance was minus 4.25 diopter spherical, minus 1 diopter cylinder, access was 10. And in the left hand, minus 4.5 diopter spherical with a minus 1.5 diopter cylinder, 160 was the access. The lamp examination was showing within normal limit. And her keratometer readings were also taken, whereas the average K was 45.75 diopter. And the base curve, average base curve was 7.4, both in CMI. Only the axis was different. And the HVAD, that is the diameter of the contact lens, horizontal one, we measured it was around 12 millimeter in both the eye. Also, we done the dry eye evaluation because she is also a software engineer, and also it is always better to do a dry eye evaluation before the contact lens fitting. In yesterday's session, we already read about this and discussed about this. And the Schoen's value were within normal limit, that is 32 mm at 5 minutes in both the eyes, and also tear film breakup time was performed 11 seconds in right eye and the 12 seconds in the left eye. So all the other examinations were also within normal limit. Based on this, we were choosing the trial lens. So now, what will be the trial lens power? And the PGC, we saw that it was minus 4.25 diopter spherical and minus 1 diopter cylinder. Axis was 10 degree. And yesterday in a discussion, we saw that in case if the magnitude of the refractive error it is 4 or more than 4 diopter, then there will be a vertex distance compensation has to be done. So especially in astigmatism patient, just based on the spherical power, you can't do the vertex distance compensation. In this condition, you have to do a vertex distance compensation for both the meridian. That is, in a 10 degree also you have there will be a power like in one meridian there will be 4.25, in the other meridian there will be around minus 5.25 will be a dioptric power. So do vertex distance compensation for both eyes separately. Even in the left eye, you have to do a vertex distance compensation for both the meridian, even in the both eye. So after a vertex distance compensation, the final power will be, that is contact lens power will be minus 4 diopter spherical with a minus 0.75 diopter cylinder. Axis will be 10 degree, and in the left eye it will be minus 4.25 diopter spherical, minus 1.25 diopter cylinder. Axis will be 160. So that will be the contact lens trial lens power. So we did a contact lens trial with a soft toric. When we saw there was like, why do we have to do the trial? It's very important to do a trial in the soft toric contact lenses instead of directly giving a prescription, because we have to check that whether the lens is stable or not. Curve was 8.6 millimeter. The trial lens power was planar with a minus 0.575 diameter cylinder. Axis was 10 and diameter was 14.5 mm. In this, when we saw in our trial lens, our main this diametric cylinder 180 was the axis and the base curve was 14.5 mm. This was the trial lens was taken to do the trial in the patient's. And this was belongs to brand B contact lens as a patient's wish. And also in this contact lens, the stabilization technique was accelerated stabilization design. And the oxygen transmissibility in this particular lens, it was 103 and the water content is 41%. So this was a trial lens fitted in the both the eyes. Once we did the trial lens insertion into a patient's eye, we gave around 5 to 10 minutes gap before doing the fit assessment. Then after that, we did the fitting assessment with the help of the slit lamp. In this, we also assessed for these components. That is, first one is the centration of the contact lens. That is, when we did the assessment for the centration, it was well centered in both the eyes and also the lens was stable. And the coverage, it was a 360-degree limbal coverage in both the eyes, and the movement also we looked for the in the right eye, it was around 0.5 to 0.8 mm post blink, and the type of movement was smooth movement. Again, in the left eye, the amount of movement was 0.3 to 0.5 mm amount, and the type of movement was the smooth movement. And also, we look for the lens lag. In this lens lag, we observe when the patient is moving, looking in the primary gaze and in the various and other four gazes, and the lens was lagging behind or it was staying behind around 0.5 to 1 mm in both the eye. So it is considered as an acceptable one. Also, we look for the push-up test. This push-up test will help us to identify the tightness of the contact lens. So when we do the push-up test with the help of either forefinger or you can use the thumb of your hand. And you can put a small little pressure on the lower eyelid and we can observe the tightness present in the contact lens over the cornea. In the right eye, it was around 40 to 50% pressure was required to see the movement of the contact lens. In the left eye, it was required around 50 to 60% of the tightness was present. Also, in a soft contact lenses, along with these five components, it's very important to even assess for the rotation. In a help of slit lamp, again we look for the rotation in the right eye. It was like whatever the trial lens we have picked, that is a brand B contact lens, it had a scribe marks in the vertical meridian, that is in the 12 o'clock position and the 6 o'clock position. When we align the slit in the center of the pupil vertically, it was exactly aligning with the scribe marks. So there was no rotation in the scribe marks. So we can tell that it's a 0-degree rotation was there. But in a left eye, the scribe marks were supposed to be in the center. When we align the slit in the center of the pupil, we got to see that the scribe marks have moved a little bit towards the like patient's examiner left hand side or the towards the in a clockwise direction. The scribe marks have moved or the rotation happened around in a clockwise direction. So when we measured like as I was telling in my before slide, when we are assessing for the orientation marks, the illumination system and the observation system has to be coaxial. In case if there is a rotation, what you can do is rotate the observation system in a slit lamp little bit, where they will be protracted also. Because of which you can tell that the amount of rotation was so when we use the same technique, we got to see that there was around 10 degree of rotation present. So when we saw the impression of this contact, this was a picture of the right eye. In a right eye, it was an acceptable fit. All the components were good and also there was a 0-degree rotation. In a left eye, when you see, is it an acceptable fit? Yes, it is an acceptable fit because all the other five components are acceptable and only there is a 10-degree rotation. So how can we deal with this 10-degree rotation is, in case if there is a rotation present. For example, in this case only, if we see there was a trial lens prescription of -3 diopter spherical with -1.25 diopter cylinder. Axis was given around 180. So when we saw with the help of slit lamp, there was a 10-degree rotation from its original position. That too, it has moved clockwise. As I was telling, 10 degree of rotation and it was a clockwise direction. this case, what you can do is, as based on the cast rule, if there is a clockwise rotation, you have to do the addition of rotation, the amount of rotation with the the contact lens prescription and also with the spectacle prescription. So if you see with this trial lens, when you add the 10-degree axis to this one, then it will become the 10 degree. From 180 to 180 plus 10, if you add, it will become 10 degree. And also you have to do a compensation of amount of rotation with the spectacle prescription also. So it will become minus 4.25 diopter spherical, minus 1.25 diopter spherical, cylindrical. And if you see patient spectacle prescription was 160 degree, right, in a left eye. So when we do the addition of 10 degree axis, it will become 170. So now in case if you are ordering the final contact lens, in case if you are ordering for this particular prescription, when we fit the contact lens of the particular this brand, then you will not be seeing it will be seeing the 10 degree amount of rotation will be there, but it will be in the original position as the prescription and the patient's requirement. So based on the fit assessment, where the final contact lens prescription was the 8.6 base curve in both the eye in a right eye. What we did is, though the spherical component of the trial lens was different, but the amount of cylindrical power was same in the trial lens, and also axis was similar. So when we based on this, what we after seeing the fit assessment, we can go ahead with the this power of the contact lens. So we ordered for the 1 month trial lens contact lens for a patient, that is with the power of minus 4 diopter spherical, minus 0.75 diopter cylinder, axis of 10 degree, and the 14.5 mm was the diameter. In a left eye, it was 8.6 millimeter with a power of minus 4.25 diopter spherical. Cylinder was minus 1.25 diopter cylinder. 170 was the axis and the diameter was 14.5 mm. We ordered this one for the trial lens, 1 month trial lens usage. Why did we order for the trial lens first? Because patient was already having the troubleshoot, or the patient was not comfortable with the brand A contact lens. Again, to cross check whether will the patient be able to adapt with the brand B contact lens characteristics or not. To cross check that, first we asked the patient to do a 1 month trial. After that, we asked them to do a follow-up visit. If patient has come back with for a follow-up visit after a month usage of the contact lens, and patient was very happy with this prescription and the contact lens also, and the patient wanted to continue using the same brand contact lens, then we ordered for the final contact lens for the 6 months usage. Where this brand B contact lens had a characteristics of stabilization technique was accelerated stabilization design, and the oxygen transmissibility was 103, and the water content of this particular lens was 41%, and the wearing modality of this particular contact lens was daily wear, and the replacement schedule was monthly disposable. So when we were dispensing the contact lens, final contact lens, also we explained to a patient about the care and maintenance of the contact lens, and also about the case, to how to maintain the hygiene both with the contact lens and also with the case. So this was the patient's final contact lens prescription for this lady. Then there will be a few questions may arise, like why did we choose brand B over the brand A? What were the characteristics of the brand B that are more good comparatively of brand A? You must be thinking about this. So like first most priority was given to patient switch. Patient didn't wanted to use a brand A, she wanted to drop out, and already in her mind had a thought of an idea that she wanted to go with the brand B contact lens. And also when we saw for the characteristics of brand B comparing with the brand B had a better characteristics. Like you can go back and you can remember that this particular patient had, her occupation was a software engineer, whereas you can see and also her working hours will be usually 10 to 12 hours, sometime it may extend to 12 to 14 hours also. And also she also works in an AC condition. So based keeping all these things in mind, if you see brand B lens had a good stabilization technique, that is acceleration stabilization design was there, and also brand B contact lens had a low water content, that is a 41%, and if you see a oxygen transmissibility in this contact lens was very good. But whereas in a brand A, It was a prism glass design, because of which there is a high chance of patient may feel a discomfort, and also here it was given the high water content. Patient had around 61% of water content was there, and if we see a DK by T, that is the oxygen transmissibility was very less, it was around 34%. So there is a high chance of patient may feel discomfort with the brand A contact lens compared to brand B. And also brand A was a hydrogel contact lens, but we prefer to go with the silicone hydrogel as she was working in the AC area and she wanted to use the contact lens for a prolonged time. That sometime it may get extended to 12 to 14 hours usage also. That is why the silicone hydrogel was chosen over the hydrogel contact lens. And already we know that why did we choose soft toric over the RGB. Again, once again, I would like to repeat, why did we choose soft toric was because the spherical component was more comparative to astigmatism, and also patient had a mild to moderate astigmatism. For mild to moderate astigmatism, based on the evidences and the practices what we did, on that we can say the soft toric will be suitable for a patient comparatively to RGB contact lens. So these are the various reasons why did we choose this particular contact lens over the other contact lenses. And also sometimes there will be a confusion. What case we saw before was it was about the soft toric contact lens, but now there will be a prescription like in our clinic we also saw a condition whereas a patient had a prescription of minus 0.50 diopter spherical with a minus 5 diopter cylinder. Axis was 40 degree, and the left side spherical power was minus 0.50 diopter spherical with a minus 4 diopter cylinder. Axis was 120 degree. So in this condition, we had a little bit confusion on whether to go with the soft toric or whether to go with the RGB. So for that also we saw a keratometric value in which we got to see in a right eye it was 47.50, and in a K2 value was 53 diopter. If you see the difference between both the meridian, the magnitude of the astigmatism will be around 5 diopter cylinder in both the eyes. So after this, we had a confusion whether to go with the soft toric or the RGB. Why did we think about soft toric? Why didn't we directly think on going the RGB? Because in the previous discussion, we saw that when the magnitude of astigmatism, if it is more than 3 diopter, the RGB is good, right? But why did we think even about the soft toric? Because in a soft toric contact lens, there is even a customized contact lens options are also there, where even you get to prescribe the contact lens in case if there is a 4 diopter cylinder. But what did we do is first I'll go with the right eye. To a right eye, as it is a amount of astigmatism, it is 5 diopter cylinder, which is high magnitude, and also if you see it is an oblique astigmatism, right? So in this condition, the soft toric is not at all suitable. So we went on with the RGB, and when we did a trial, patient vision improved to a 6.6. When with this prescription, patient in a spectacle, he had a vision of around 6 by 22. But when we did a trial in the right eye with the RGB contact lens, it reached to 6.6. So for the right eye, we decided to go with the RGB contact lens. So as I was telling, for the left eye, there is an option of giving the soft toric also and the RGB also. So for the left eye, first we did a trial with the customized toric, but when we saw the vision improvement, there was no good vision improvement. Also, patient was not happy. Obviously, when the patient will compare both the vision with the right eye and left eye, they were more comfortable with the right eye vision than with the left eye. So also we decided in this condition, we dropped out the idea of giving soft toric. We went on giving the RGB contact lens. So in this condition, when the amount of cylinder is more comparative to a spherical, it's always better to go with the RGB contact lens when there is also oblique astigmatism present. So it's always better to go with the RGB contact lens. If we give the soft toric, there will be mislocation of the axis also will be present, and the lens will not be stable over the cornea also. So for this kind of patient, we prescribed the RGB, and patient was very happy with this 6.6 vision, and patient was using continuously a contact. And this was about the when to choose a soft toric and or the RGB in the astigmatism management. And these were my references for my evidences. And thank you.
Thank you, Ashwini. That was an interesting presentation Although I'm sorry that internet connection was quite unstable, because of which the audio was quite poor. We'll try to remedy this and come back to the better presentations from tomorrow.
Okay, sir.
Ashwini, there are a couple of questions that we have.
Okay, sir.
There's one question from Mr. Zaman. He's asking how much rotation is acceptable.
Answering
Second,
to that,
he
yes,
wants to
sir.
know, can over-refraction be used to detect change in axis due to rotation?
Okay. So answering to our first question, how much of amount of rotation is acceptable? Around 10 to 20 degrees are acceptable. In case if there is a 20-degree rotation is present, better to change the company of the lens. Maybe you can change the stabilization technique of the lens, and you can try to reduce the first of all, to answer that one, in case if the rotation is less than 20 degree, then you can do a compensation with the prescription, and then you can go with the trial lens final contact lens prescription. Whereas in case if it is more than 20 degree, it's better to change the company of the contact lens, or maybe more than a company, you can change the stabilization technique of the very other contact lens option you can go. Still with the same various stabilization technique in a soft toric contact lens, still you are able to see at more than 20-degree rotation, then it's better you can think about giving the RGP. You can look for the topography report of the cornea, then you see that whether to better to go with the RGP or still sticking to soft toric. So based on that, you can decide. And with the over refraction, yes, you can do, but it is though it is not a standard way to finalize the amount of rotation to check with the over refraction, but there is a method to do that one. Once you fit the contact lens, the patient, if you want to confirm the axis, the amount of rotation present, you can put a trial frame, and over that you can see the amount of the cylindrical lens you can keep it at the one particular meridian. The patient will be seeing them clearly. So based on that, you can confirm that what is there is a location. Sorry, the mislocation is present or not. You can cross check. Hope
Thank
I
you.
have answered Noos's questions.
The next question is from Mr. Devakar.
Yes.
He wants to know if the toric lenses rotate when we
Yes.
turn our head upright down.
Okay, answering to that question, there are studies which says that in a olden days it was like when you go back around 2005 before the study of physics, yes, there were evidences which says that the gravity will have the power, gravity will make a difference in the mislocation or the orientation in the markings. But again, there are recent studies which says that gravity will have a minimal power, or there is no significant effect on the mislocation of the orientation marks. So the lens will not rotate. There is a very minimal amount of rotation will be present when the patient will have the change in the head position, which says. But whereas the lid movement or the lid force and the tear film force will be more significant on the changes in the contact lens rotations.
I think what he's talking about is the head turning upright down.
Okay. Yes, sir. When the person when they rotate the head down towards the down, in that condition, there will be a very minimum amount of effect will be there, the gravity effect, and it will be very less significant difference. It will be there. I see.
Okay, thank you. I don't see any other questions right now. Can we does anyone have any more questions? Well, I don't see any more questions for you. Probably we will see if we get more questions. We'll ask you later. Thank you very much for the wonderful presentation. We will come back to you tomorrow, same time, same channel. And tomorrow the topic is, we're talking in terms of irregular cornea corrected with contact lenses. Dr. Zaman will be handling that. So see you until then. Have a safe time. Thank you.
Thank you so much.